Hello, and welcome to today's webinar, Living with Familial Chylomicronemia Syndrome, Understanding, Managing, and Coping Together, presented by the FCS Foundation. My name is Chris Brine, and I will be moderating today's program. We're excited to have an audience of FCS patients, caregivers, and advocates join us today. Our faculty today includes Dr. Seth Baum and Dr. Al Freedman. Dr. Baum is the Chief Medical Officer of the Flourish Research, past president of the American Society for Preventive Cardiology, and clinical affiliate professor of medicine at Florida Atlantic University College of Medicine. Dr. Al Freedman is a psychologist, educator, and rare disease advocate with more than 2 decades of experience working with individuals and families affected by rare diseases and disabilities. We want to extend a big thank you to Ionis and Arrowhead Pharmaceuticals for their generous unrestricted educational grant to allow this webinar to happen. Before we begin, please note this program is being recorded. All lines have been placed on mute to prevent any background noise. We will have a Q&A session at the end of today's program and encourage you to submit your questions throughout the program via the Q&A feature on this platform. Today's agenda will encompass a clinical overview of FCS, followed by a discussion on the social and emotional impact of living with FCS. Now, without further delay, I would like to turn the floor over to Dr. Seth Baum.
Thanks, Chris. Thank you, sponsors and all the attendees. It's great to be here today to give you an overview of FCS. And I figured I would start with a discussion of triglycerides, what they are. Triglycerides are at the root of FCS issues, and many people may not really understand what they are. So here we see them. Triglycerides are a major component of dietary fat, and frankly, almost all of our dietary fats come in the triglyceride form. And if you look at this this image, you see on the left glycerol, then 3 fatty acids, then fat, which is a triglyceride. So glycerol is the backbone, and that's what 3 fatty acids will join to form a triglyceride, 3 fatty acids. And this is what they are. Triglycerides are fats, and fats like cholesterol cannot mix with blood, which is an aqueous solution. So just like if you were making salad dressing, for example, and you had water and vinegar and oil and you shook it up, you'd see these bubbles of fat. Well, the same thing would happen in blood if triglycerides were just floating around freely. So the body very smartly packages them into what are called lipoprotein particles. And there are 2 ways to develop these triglyceride-rich lipoprotein particles. Those are particles that have a ton of triglycerides in them. On the top of this diagram, you see a liver, and the liver is where VLDL, or very low density lipoprotein particles, are manufactured. They contain about 80% triglycerides, so a lot of triglycerides. And then you can see what happens to them downstream as they become metabolized, ultimately becoming LDL, or the bad kind of lipoprotein particle that leads to atherosclerosis. Now, they're metabolized by delivering their triglycerides to skeletal muscles and other muscles, the heart, where they can be used for energy, or stored by fat for energy at a later time. Below that, you see the gut, the intestine, and that's where we absorb the fats that are in our diets, and we make chylomicrons, or the CM that you see coming out of there. Chylomicrons are very, very large, the largest of the lipoprotein particles, containing 95% plus triglycerides. So they are super triglyceride-rich particles. They too have the same, or not the same, but a similar fate in that they're going to deliver their payload, the triglycerides, to be used as energy by muscles or stored as fat by fat, stored as energy in fat cells. The triglyceride ranges are a little bit arbitrary. We say Anything under 150 milligrams per deciliter is normal, and greater than 150 is abnormal. In truth, we think less than 100 probably is where we should be. But when you look at this chart, you'll see that the lion's share of people have normal triglycerides. So about 75% of the population will have normal triglycerides, 25% greater than 150, and most of those, almost 24%, are under 500. The over 500 is a very small patient population. So why do we worry about this smaller patient population of very high or severely elevated triglycerides? It's because there's a tremendous risk of acute pancreatitis, which can be devastating, quite frankly. And it's interesting and important to note that the risk of pancreatitis goes up in a continuous fashion, really, as triglycerides rise. So at a level even of between 200 and 500, there is actually an increased risk of pancreatitis from that small elevation in triglycerides. But when you get up over 1,000, the risk becomes extreme. You see a 17-fold increase risk at those very, very high levels. And those are the levels where patients with FCS typically sit. Diagnosing FCS can be challenging. Some of the things we focus on are this persistent elevation of triglycerides over 880 or over 1,000, in spite of good lipid-lowering therapy. Patients with FCS don't really respond to lipid-lowering therapy. There are no or well-controlled secondary causes of high triglycerides, and that's because there are many things that can elevate triglycerides: medicines, overweight, diabetes that's out of control. There's a whole variety of things. We need to control those, and then if you still have an elevated triglyceride over that 880, well, then we more seriously consider that diagnosis of FCS. Recurrent abdominal pain or acute pancreatitis, of course, are things we look at as well. An early age of onset is more common in FCS than other forms of severe hypertriglyceridemia. Typically, but not exclusively, patients are normal weight. Patients can develop eruptive xanthomas, painful lesions that don't frequently occur, quite frankly, but if they do, it points to FCS. And lipemia retinalis, which is a condition where there's fat in some of the blood vessels in the retina. And it's important to know that this does not adversely affect vision. It's something we see on physical examination, but will not cause visual abnormalities. Now, biallelic mutations in FCS causing genes, very, very important. FCS is a condition where mutations in 5 major genes that impact triglyceride metabolism in a specific way that I'll show you in a second. 2 mutations. Biallelic means a mutation from mother and a mutation from father. And then we also have a couple of scoring systems, the North American FCS scoring system and the European scoring systems we can use to help us make this diagnosis. What are we really trying to distinguish here? Well, we're distinguishing MCS, or multifactorial chylomicronemia syndrome, from FCS, or familial chylomicronemia syndrome. And here you see a number of clinical and genetic features that help us make this distinction. First of all, it's important to note the frequency, the population frequency. FCS is very rare, 1 to 13 per million people, whereas MCS, although it's not common, it can be up to 4,000 per million people, so much, much more common than FCS. From a genetic standpoint, they're both genetically driven, but the genetic cause of FCS is this monogenic, these single large impact mutations. So mutation in one of these 5 genes that impacts lipoprotein lipase, or the enzyme that's responsible for the metabolism of triglycerides. So you need one mutation from mother, one from father. We don't always identify it, and it's important to know this. We don't always see it in patients with FCS because we haven't identified, frankly, all the mutations that cause this. But that's what we're looking for. Whereas in MCS, it's polygenic. There are about 30 plus genes that have small effects on triglyceride metabolism, and a multitude of slight mutations or disturbances in these genes can lead to MCS. The age of onset, I already told you, often older in MCS. The MCS patients are often overweight. They have diabetes or metabolic syndrome. The secondary factor is very common in MCS, not so in FCS. And again, the response to pharmacologic treatment is very, very poor with FCS, whereas it can be a pharmacologic treatment can be effective in MCS. This is just an example of that North American FCS scoring system. There are a number of different metrics we input into this calculator. We could determine the likelihood of FCS. So, why are triglycerides so markedly elevated in FCS? Well, I've told you that there's this genetic cause, these monogenic issues with these five canonical genes where we have mutations. And what happens is they're all either lipoprotein lipase or lipoprotein lipase related. The support, genes that support lipoprotein lipase activity. So in FCS, when you have these two mutations, one from mother, one from father, you basically end up with essentially no lipoprotein lipase activity. And the biggest concern we have, and I again alluded to this earlier, is acute pancreatitis. Acute pancreatitis occurs in most of 75% or so of patients with FCS. Recurrent pancreatitis rates can be around 50%, and mortality rates from acute pancreatitis in this patient population frankly, are exceedingly high. And we have evidence supporting the fact that when triglycerides lead to pancreatitis, mortality is higher than when other things lead to acute pancreatitis. In addition to all the physical issues, the pancreatitis being the dominant one, there are real emotional and cognitive symptoms that occur. And Dr. Freedman is going to expound on this, but I just wanted to have one slide up to sort of set the stage for Dr. Freedman. But forgetfulness, brain fog, other psychological, emotional issues related to the very, very stringent diet that's required in managing patients with FCS. These can lead to some very significant and debilitating psychosocial symptoms. So we're very happy that we now have our first treatment option available for FCS, and it was approved in December of 24. There's also an anticipated second future treatment option later this year. And both of them rely on a type of protein called ApoC3 or apoprotein C3, excuse me, which inhibits two mechanisms for normal triglyceride clearance: the lipoprotein lipase independent and lipoprotein lipase dependent pathways. And as I've already told you that in FCS, lipoprotein lipase is essentially inactive. We're really relying for these therapeutics that impact ApoC3. We're relying on the lipoprotein lipase independent pathways. So these are the pathways whereby there's hepatic clearance of these triglyceride-rich lipoproteins, and ApoC3 is inhibiting it. So these therapeutics will basically diminish ApoC3 in order to release, let's say, this lipoprotein lipase independent pathway to degrade or metabolize these these triglyceride-rich lipoproteins. The first one I'm going to discuss is olezarsen and their clinical data from the pivotal phase 3 program that led to the approval of the drug in December of 24. And just as an overview, we see on the right ApoC3, and we see at month 6 a significant drop in ApoC3. And in conjunction with that drop, we see triglycerides fall. So again, we're basically releasing that lipoprotein lipase independent pathway and allowing it to work more effectively to reduce triglycerides. We look at what's the most important thing here, right, is pancreatitis, and we see that the numerical incidence of acute pancreatitis in participants treated with olezarsen was lower compared with placebo. We see here this one episode of acute pancreatitis at about year 1 in the olezarsen arm, and 11 acute pancreatitis events occurring in 7 patients or 7 participants throughout the course of the study. Whenever we talk about efficacy, we need to look at safety, and we can see that the drug was generally well tolerated with nicely balanced effects across these two doses. We see no drug-related SAEs, which is important to note. Next, we'll look at the plozasiran clinical data. And plozasiran, excuse me, has its PDUFA date November 18th. That's the date that we're hopeful that FDA will approve the drug, and it's anticipated will do so. And then we would have a second therapeutic available for FCS. And we see similarly ApoC3 on the right, triglycerides on the left, and what happens over time. We see this drop in ApoC3 and this drop in triglycerides that we would expect as we diminish ApoC3 and again enable that lipoprotein lipase independent pathway for hepatic degradation of these triglyceride-rich lipoprotein particles. We see here that plozasiran reduced the incidence of acute pancreatitis, and again, you see on top plozasiran with 2 acute pancreatitis events and 5 in the placebo arm for a statistically significant reduction in acute pancreatitis. And then finally, again, a summary of adverse events with a well-tolerated medication, demonstrating fewer premature discontinuations with plozasiran, and again, a nicely tolerated medication. And now I will hand it over to Dr. Freedman, who will discuss living with FCS, mental and emotional impact.
Thank you. Thank you very much, Dr. Baum. My name is Al Freedman. I am honored to be here. Thank you for that comprehensive presentation, Dr. Baum. I learned a lot just now myself. I am honored to be here. I'm thankful to the FCS Foundation and sponsors for including me and inviting me to the presentation today. I am a psychologist, and I specialize in supporting the needs of patients affected by rare diseases all over the world, and organizations supporting patients affected by rare disease all over the world. I come to this work because of a personal experience. I'm also a rare disease caregiver. My son, Jack, was diagnosed with a different rare disease called spinal muscular atrophy 30 years ago, and we were told that he would live to the age of 2. And thankfully, Jack didn't fully cooperate with that prognosis, and he lived to the age of 26. And in those 26 years, I've learned a lot about rare disease at a personal level. And as a practicing psychologist, I have now focused my attention and specialized in helping others who face similar challenges. So I consider it a great privilege to do the work I do with communities like yours and families facing adversity as you do. The photograph on the right is a symbol of my professional work. This is a group of patients with SMA, my son's condition, at our conference, where I'll be in about 2 weeks. I work with patients individually and in groups and with communities, doing what I can to support their social and emotional needs and psychological needs. And these kids have taught me a lot over the years, and so many other kids and adults have taught me so much over the years about the lived experience of the challenges of rare disease. And what I'm going to do today is to walk through a few lessons I've learned along the way about the social, emotional, and mental health challenges that we're all challenged by when we're in this world of rare disease. And the first lesson I've learned is that having a rare disease and the experience of finding out we have a rare disease can be very traumatic. In your case with FCS, 1 in a million, literally, 1, 2, 3, or 4 in a million is a very unusual and rare condition. This is why we call it rare disease. And I'm not an FCS specialist, but I've read up and learned a lot and had a couple of patients with your condition. And I've learned about the challenges that come with finding out that you have FCS because of oftentimes not having an accurate diagnosis quickly, wondering what's going on when you have these symptoms and don't know what to call them or where they're coming from. And for all of us affected by rare disease, regardless of the condition, there's sort of the life we have before this change in our lives when we find out we have a rare disease and the life we have afterward. And it takes a lot of time to reorient once we find out we're in this club we didn't choose to join. It certainly took me a long time to reorient to the news that our baby had this incurable disease. One of the questions I'm asked quite often as a psychologist is it normal, Dr. Al? Is it normal that I can't sleep at night or that I worry all the time or that I think something else bad is going to happen to me or my family? Our minds can play tricks on us when we receive a diagnosis and we hear something so serious and so life-altering. The answer to that question, is this normal, is 99% of the time, yes. These symptoms are a normal reaction to a very unusual and rare situation. And anybody who receives life-changing news like the news you just received would react in very much the same way. And I'll talk a little more about that as I go. That's lesson number one. The trauma of finding out that we have a life-threatening condition and a rare condition is significant. Once we reorient to the new world we find ourselves in your case, FCS, we live with a lot of uncertainty. And it's very hard to live with uncertainty. It's a hard way to live because uncertainty leads us to feel anxious, understandably. In my work as a psychologist, I see rare disease patients every day who struggle with different levels of uncertainty and types of uncertainty. First is the existential level of uncertainty. What does this mean for me, this rare disease? What will it mean for my family? How long will I live? Where's my place in the world? And how will I manage with all the uncertainty that comes with this rare condition? Will my symptoms flare up? Will I need to go to the hospital? In your case, and in my case with my son and so many others with rare disease, we're always vigilant and always watching and always worried because we don't know if the symptom that we're noticing is going to turn out to be not very serious or serious enough to end up back in the hospital. I spent 300 or 350 nights with my son in the hospital over those 26 years, and it's a hard way to live. I drove around with a suitcase of clothes and a toothbrush in the back of my car for 20 years because I never knew because of the uncertainty when we would end up in a hospital. With FCS, you have additional challenges of your diet and are the labels on the food accurate when you're told that the ingredients in the food that you're offered are safe. You may still be uncertain about whether it's really safe, and other people may not understand that. The living with uncertainty is the second lesson I've learned in rare disease that I wanted to share with you today. It's very common and it's very challenging. The third lesson I've learned, both as a dad and as a psychologist, is that it's very important for us to find hope when we are offered a rare disease diagnosis, when there's little we can do to help with the disease. My own son's condition had no treatments back in 1995, and thankfully there are 3 treatments now for his condition, which brings hope. As Dr. Baum just said, FCS now has a treatment, and there are more coming. That helps us have some hope. 30 years ago, when we were given no hope, it helped me and it helped so many other people to connect with others who've been there before, others who have FCS and who are living productive lives and who understand what it feels like to be faced with this challenge and have managed to overcome the challenges, the real significant challenges that come with the symptoms and the flare-ups and the pain that are experienced when you have the pancreatitis. It really helps to be connected to other people who can lift you up and offer you hope about the situation you're in. Many of the people that I received hope from were from the SMA community, and they gave me hope that they were able to manage this very difficult experience as parents or as patients. When you spend time around hopeful people, you become more hopeful. You don't need a PhD in psychology to figure that out, but I include this because it's fundamental to the work I do and fundamental to our mental health when we're faced with unusual challenges. Which leads to the fourth lesson I've learned along the way, that mental health is important too. And that's obvious coming from a psychologist, but I can tell you that it often lags behind. Our attention to mental health lags behind, understandably, our attention to medical and treatment and physical symptoms. For 26 years, I didn't have time to talk about how I felt about all of the stuff I was dealing with my son, because I was busy keeping him alive and needed to focus on his care and his wheelchair and his ventilator and his feeding tube and all the crazy things that came from his condition. You have a lot of challenges on your hands too with the condition that you have. And it's important that you take care of yourselves and focus on the things that you can do to keep yourselves mentally healthy while you're managing the physical challenges. With FCS, there's obviously stress that comes with interruptions with socialization because of all the challenges with your limited diets, with your work and your jobs, with relationships. All of these aspects of your lives can be and are sometimes disrupted. And the anxiety that comes because of the uncertainty and these disruptions, and sometimes not feeling understood, and the uncertainty and the anxiety about symptoms coming, all would contribute, understandably. It would be expected that stress and emotional challenges would come. I'm often asked as a practitioner, when should I seek mental health support? And the answer to that question is, when your symptoms interfere with your day-to-day functioning, you should seek professional support. In my estimation, large majority of patients with rare diseases benefit from and deserve to have additional emotional support. And that can come individually with a professional, but a lot of the work I'm doing these days is through groups. You're here as part of a group today, and support groups through community go a long way towards helping people's mental health. When I facilitate support groups, which I do about 10 times a month for 5 or 6 different rare diseases around the world, I find so much support, and so much of the mental health needs are supported by peer support rather than by a doctor support. There is strength in numbers, which leads to my fifth lesson today, which is that community strengthens and supports. There are a lot of types of communities. We have our work communities, our school communities, our neighborhood communities, our faith communities, and all of them have the ability to support us when we're in an unusual situation. All of them supported me and my family along the way. But the special and unique support that can come from a rare disease organization like your FCS Foundation, I find to be the most important resource for patients and caregivers affected by rare disease. This is the club that we didn't choose to join, but when we allow ourselves to be part of the community that supports us, this club that we didn't join, we interact with people who do get it. So much of the experience we have when we're experiencing rare disease personally is that other people can't get it because it's such a rare situation that people outside of our community have a hard time understanding and relating to the challenges we face. When we stick with our rare disease communities, we share knowledge with each other, we support each other, and we trade information about who the doctors are who know best about, in your case, there'd be information about dietary strategies, about dietitian. I see rare disease communities in groups sharing so much knowledge and providing so much support for each other, which strengthens and supports each of us and each of our families along the way. I've also seen in my travels, I attend many rare disease conferences and meetings with groups like yours, And one thing I've noticed is that rare disease communities are all open-hearted and compassionate, and people are nice to each other. Everybody lifts each other up. They don't put each other down, which can happen in our society these days. Everybody lifts each other up and strengthens and supports each other in a very, very positive way. So I encourage all of you, as you're participating today in this program, to participate in any opportunities that you're able to connect with others who share the challenges that you face. In 2 weeks from now, I'll be in California at the conference that you saw the photograph of the children when I began. That's like my extended family, 30 years of relationships with other families who have kids like mine and adult patients who have the same condition. And it's like a family reunion for me. And that's what it's like for people who allow themselves to be part of the club that we didn't choose to join. Community strengthens and community supports. The sixth lesson that I'd like to share with you today is anything is possible. When we receive a rare disease diagnosis, we're told the doctors are doing their jobs when they tell us about the problem, the name of the problem, the symptoms of the problem, and all of the risks and the things that are going to be challenges ahead. I was told that my baby would not be able to walk, would not be able to swallow food safely, would not be able to go to school, would not be able to blank, 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 and blank, and would not live past the age of 2. And that's a very overwhelming experience for us in rare disease. Doctors are doing their jobs by teaching us what we need to know to stay as healthy as we can, as long as we can. We hear a lot about what's not possible. I think it's very important in my work as a psychologist to help rare disease patients and caregivers focus on what we can control and what is possible, knowing that there are many things that are going to be challenges for us. I never would have imagined that my own son would finish high school, would have 3,000 Facebook friends, would have 2 part-time jobs, would be able to type 20 words a minute with an eye gaze unit. He couldn't move a computer mouse, had all kinds of friends, went to summer camp, and he packed a lot into those 26 years in ways that nobody imagined when he was diagnosed as a baby. And over again, I find myself inspired by the patients and the families who find their way to what is possible and focus on the things that we can control as a way to stay mentally healthy, be hopeful, and to overcome as much as we can all the very real challenges that come with a rare disease. So the sixth lesson for today is anything is possible. And my final lesson for today that I'd like to share with you has to do with the idea that we don't have only bad days when we have a rare disease. A lot of people assume when they hear about our disease or we teach them about our disease, in my case, when they saw my son driving his wheelchair through a mall, they would look at us oftentimes with pity. Every day is a bad day. And we also remember what the doctors told us upon diagnosis. But along with the rare disease, it took me like 20 years to figure this one out as I chased my son around the town. He was like the mayor of the town. And it took me all these years dealing with rare disease patients and families to discover that along with the rare disease comes some rare gifts. And they're positive and hopeful gifts that most people don't have and most people don't give. The first one is the gift of perspective. Everybody else's big problems are our small problems. Every time my boy drove his chair in the room, everybody else's big problems got small very, very quickly. We're not the people who worry about the small stuff when we're affected by a life-threatening rare disease. I'm not the guy who gets all worried at the airport or angry when the airplane's going to be late. I'm not the person at the airplane counter yelling at somebody because the plane is late. That's a small problem to me. Rare disease teaches us the difference between what's important and what's not important, what's a big deal and what's not a big deal. Rare disease teaches us about resilience. As I learned about FCS and have met with patients with FCS, a great respect and admiration for the resilience that you all have when you have these episodes that are very painful and very scary, and then you bounce back. My son and so many others like him in rare disease, affected by rare disease around the world, have resilience, have perspective, have resilience, and are able to bounce back from adversity with great grace and great dignity. Rare disease offers us that gift of resilience. Creativity. We can't do things, and you can't do things the same way everybody else does. You can't go out to dinner the same way everybody else does. I couldn't take my kid places where there were stairs. He couldn't pick up a pencil and sign a piece of paper or move a computer mouse. There are so many obstacles in the way when we're affected by rare disease, and we can't do things the same way everybody else does. So we get very creative and find ourselves with people, professionals who support us and teach us how to do things differently in very, very creative ways. And I can only imagine, because I'm not affected by FCS, all the creativity that comes with the challenges you have with your diets and taking care of yourselves. You have to be doing things very creatively in order to manage. Creativity is a gift. Compassion. I can't tell you how many open-hearted, compassionate people that my son led me to during those 26 years who continue to be connected to me and to my family. People who are open-hearted and compassionate choose to get involved in our lives and in our care. We don't choose FCS. We don't choose any of these rare diseases, but other people who don't have a rare disease, like Dr. Baum and like the folks behind the scenes on this webinar, and like my son's nurses who came in the middle of the night to take care of him for 12 hours at a time overnight, they didn't have to do that. They could be doing a lot of other things, but they make the choice to help us because they're open-hearted and compassionate. Rare disease comes with that gift of compassion. People are drawn to us. My son was like a magnet for compassionate people. And finally, rare disease comes with the gift of connection. And this goes back to the, the, the point about community. We are very strongly connected in rare disease because we need to be, we need support, and we find ourselves connected in very unique ways with the people who share the unusual experience that we have. The community that you're a part of, the FCS Foundation, the community that I'm part of with my son's condition, this is like extended family for me, connection. The kids that went to my son's camp who all used ventilators showed up at his memorial service and are still checking on me to make sure I'm okay. There's a strong connection between those of us who find ourselves in such an unusual situation. And all of these rare gifts of perspective, of resilience, creativity, compassion, and connection, and I could put a slide up with 20 more, are all greatly important to us as we face the challenges that come with rare disease. Helps us to manage our mental health and to celebrate each day and appreciate every day in a way that other people don't often appreciate. Rare disease gives us that sense of perspective and appreciation, and all of these are gifts that are unanticipated, gifts that come with such a challenging situation. I thank you so much for your time and your attention, and I hope what I've shared with you today has been helpful. I'm honored to be part of this, and Dr. Baum and I are going to now move on to the Q&A time. We have a few minutes to respond to the questions that you have. And thank you again for including me today.
Thank you, Dr. Baum, and thank you, Dr. Freedman. Great information for our audience today. We did have a few questions come in, and we'll try and answer as many as we can. First question that we see to the panel. is about brain fog, memory loss. Dr. Freedman, could you give us any insight in your experience with rare disease and potential memory loss?
Yes, I'm not a expert on FCS and brain fog, but I can tell you all that in my work as a psychologist, there are many other rare diseases that have unusual manifestations, cognitive manifestations, and uh, brain fog is not an uncommon symptom for me to hear about from rare disease patients in other areas as well as FCS. I'm not knowledgeable about the specific source of brain fog within the context of FCS, only that this is a symptom that's not unfamiliar to me as parents, as patients and caregivers describe some of the challenges they face. Brain fog is a frustrating symptom and causes additional stress on top of the other stressors that you all face.
Thank you. Dr. Baum, with that, with your patients with FCS that you manage, do you hear this? Do they share this with you?
They do, and so a number of them have experienced brain fog. Some, I've seen patients with FCS who are entirely asymptomatic, and who have not had abdominal pain or pancreatitis. They're more uncommon, but I have definitely seen that. And even in one is coming to mind with genetically confirmed, right? So this is, you know. Yeah, so I think the symptoms definitely vary, but the brain fog is common um, among the symptoms.
Thank you. Thank you both. Another question here. This is a good one. Are we close to gene editing in the treatment or management, I'd say treatment of FCS? Dr. Baum,
Yeah,
anything you can get insight?
so I would say it depends how you define close. I don't think we're close, meaning within a couple of years, but certainly there's a lot of interest and activity in the gene editing world. A number of different companies pursuing different therapeutics for different diseases. Just as a bit of interesting and important information. There was just an FDA panel, I think it was early this week, that discussed gene editing, and it was very positive. So it seems that the FDA is very much on board. At least that's what came out of this particular meeting. To Dr. Friedman's point about hope and hope begetting hope, I am hopeful that there will be something in the let's call it the not too distant future.
Seems to be potentially the wave of the future
Yeah.
with medicine. So we will see something to that. Another question, and this is actually directed to both of you. When in your training and in medical school, as clinicians, are you taught how to manage, how to discuss challenges with patients with rare disease? And it says, is it a quick lesson? Dr. Friedman, I'll start with you.
Well, for me, it was not a quick lesson. It was 26 years taking care of my son. I certainly learned a good deal in graduate school all those years ago to get a PhD in counseling psychology. But I call my son Professor Jack because I don't think I would feel credible being here with all of you without the training I received from him. So no, there wasn't much, if any, specific to rare disease for the training of a psychologist. I will tell you, though, that one of yesterday's meetings for me was a planning process to develop training programs for other psychologists, training modules, 8 of them, 12 hours of training that I'll be helping to provide to peers so that other psychologists can have some training in rare disease that they might not get in school. And I'm looking forward to developing that training.
Excellent. Thank you. Dr. Baum.
So I was graduated from medical school 40 years ago, and so it's been quite a long time. I would say, in my experience and with what I know about what's being taught in medical school today, it's not emphasized. We certainly learn about rare diseases, but it's one thing to learn about the physiology, the pathophysiology of a rare disease, and another thing entirely to have the skills that Dr. Freedman is talking about to be able to help patients on a broader basis and address the cognitive and emotional and psychosocial issues that are frankly equally important. So I think it's underemphasized.
Thank you both. Another question. If I can manage pancreatitis hospitalizations through my diet, do I need to use any of the new drugs? It's a great question.
That is a great question.
Yeah.
Well, so managing pancreatitis, I've definitely seen patients do this where symptoms start developing, patients make themselves NPO at home, stay at home, and avoid the hospitalization. You're still experiencing a problem, right? You're still developing acute pancreatitis. So to me, the goal is just not to develop that at all. So I would favor never having any abdominal pain or pancreatitis over developing it and just not being hospitalized.
Thank you. Another question, and you've discussed this, Dr. Baum, in your talk up front. In terms of symptoms, probably varies. However, the question is, when do symptoms start to appear in FCS?
Yeah, so it's a great question. If you look at the classic definition of a patient with FCS, the patient presents in childhood with failure to thrive, and it's like this very obvious presentation. We don't see that often in my experience, and I've seen a number of patients with FCS. So I don't think that's the norm, and I do think that patients vary tremendously. I've seen patients who present to us, much later in life, 20s, 30s, 40s. And then I've seen, as I said earlier, other patients who literally do not have any symptoms. Again, just very variable. I think the important point is we as clinicians need to be much more aware of the possibility of FCS. So when we see patients in our clinics and patients have very high triglycerides, the level we're discussing greater than 880 consistently, we have to start thinking about the possibility of FCS, not be limited by the absence of symptoms or the absence of a prior episode of pancreatitis. We have to be open-minded and consider that possibility and really address it and look for it, pursue the diagnosis. So I think that's very important.
Another one, and this is for both of you, in terms of a care team for patients with a rare disease, um, what clinicians who should be involved in the care for patients who have rare disease? Dr. Freedman, I'll start with you.
Well, in addition to the medical specialists that Dr. Baum will tell us about, I find it's really helpful for patients and families to have access to a mental health professional, whether it's a counseling person, a social worker, psychologist, in some cases, genetic counselors. I just did a talk with National Genetic Counselors Group in Chicago last week. Um, there needs to be somebody who helps the patients to have the space to talk about how do I manage all this socially and emotionally alongside the doctors and the medical professionals who are providing the medical treatment. That's sometimes offered in rare disease in hospitals and in clinics, sometimes not. But when it can be, it goes a long way so that patients feel they can ask all the questions they're afraid to ask, to connect with other families. Sometimes the social workers and the folks in the hospital have permission from other families to connect them to each other and to an organization like FCS. It was a social worker who told me about the club I didn't want to join that now is my family. So these kinds of professionals are um, they're important, sometimes ancillary, but they're important in a different way. as you're interacting also with Dr. Baum and the professionals that he's going to list.
Thank you.
Yeah, so
Dr.
so
Baum?
I would just add one thing to what Dr. Freeman just said. Based on your talk that you just gave, I would say support for the family members and caregivers as well. And
Yes,
I bet that just doesn't happen often enough. So it's somehow to bring that to treat that group as well.
that's right.
Yeah. So for FCS, nutritionist, very, very important. A specialist who has understanding of FCS, which is not very common. That might be a lipidologist. It could be an endocrinologist, a cardiologist. Um, but you have to, I think, seek out somebody like that. And when I say that, and as it rolls off my tongue, I'm saying you have to, putting the onus on the patient. Unfortunately, I do think patients have to be their own advocates, because if you're not your own advocate, in our current medical system, you get left behind. And I will tell you, I know that from my own personal ailments. You got to advocate for yourself. Um,
Yeah.
so if an individual has experienced pancreatitis, a pancreatologist, somebody with expertise in the pancreas would be wonderful. Short of that, the hepatologists often know a lot about this. And I would say that rounds out a pretty good team. And a
I like,
geneticist maybe as well.
and I'd like to add one other compliment your comments, Dr. Baum, with it's important that you find professionals who know more about the disease than you do. One of the things that scared me the most when my baby was diagnosed was hearing the doctor say, "You're going to become the expert on this condition, Al, and you're going to teach us." And when you're starting out, that's not what you want to hear because you're terrified, and you want to find people who will help you feel safer because they know more about the condition than you do. And in rare disease, it's not easy, as you said, to find specialists who know about a condition that's so unusual. But it sometimes takes some work to find those specialists, but they bring peace of mind to patients when the doctor knows more than the patient about a rare disease.
And just to piggyback off that, and that's part of being your own advocate, is
That's
ensuring
right.
that you find that
Yeah,
person. Yeah.
that's right.
Fantastic. We're coming up on time. I do want to have this. We have a few more slides. I want to share some resources and close out the program. However, there is another question which seems to be perfect for our as we come to a close. If to the panel, if there is one major takeaway from today's webinar, what would you say as a patient I should take away? And if there could be more than one, but they're asking just for one. Dr. Freedman.
I'd go with, if I have to pick one, it would be never give up. Never give up. Just stick with it, stick together, and never give up. You never know what's possible ahead.
I,
Thank you.
I guess if I have to go with one, I'm going to say be your own advocate. Actually, I think,
Great.
yeah, I think that's an important lesson.
Thank you both for the information. And to our attendees, on this slide, you'll see there are resources that are available. They're listed here, and you can also visit our website, livingwithfcs.org, listed as well, with the wealth of background and information to assist you, your caregiver, and family members if needed. Thanks, everybody. Thank you, speakers, for sharing your valuable insight today, and to the audience for your interactive participation as well. I'd like to now hand it over to the FCS Foundation's co-president and founder for closing remarks, Melissa.
Hi, everybody. Thank you so much for joining. It was so nice to have you here with us, Dr. Freedman and Dr. Baum. Thank you so much for your time and your expertise and sharing this with our patients. We really appreciate everyone being here. I think, I'm going to kind of piggyback on that, Chris, about the one takeaway. As a mom of a daughter with FCS, Juliana is 12 now, and doing well, but now at an age where you can see you know, she's experiencing those regular teenage things of wanting some independence and you know, my wanting to also make sure that her diet is appropriate and that she's staying healthy. Um, it can be very taxing. My day job as a mental health counselor, I see with a lot of different clients who struggle with chronic illness that it's an ongoing issue that they face. So, you know, my takeaway is, you know, your mental health matters. This is a big burden to carry, and there's no shame in asking for help and acknowledging that when you need to, and kind of taking a step to find people who can help you, not just medically, but also emotionally to deal with what's happening. So thank you all for being here. I really appreciate it.
Thanks.
And that concludes today's program. Thank you for joining.